Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 23rd episode of Optometry Series 2.0. I'm very happy to welcome my team members, Ms. Anshul and Ms. Meenakshi. Thank you both of you for joining. And Anshi ma'am, so last episode we dealt with the anatomy of EOM and cranial nerves, ma'am. So today's topic is obviously we're going to pitch in into the disorders of cranial nerves and EOM. So who's our moderator for the day, ma'am?
So thanks, Gomati. Today we have a moderator, Mr. Amit, Amit. He's working at Shankar Nethralaya. So today's topic, as we are almost close to the posterior segment of the eye, we'll be closing down with the diseases. And thank you, Amit, for joining us today. I'll request the MC to please introduce Amit.
Over to you, Saffin.
Good evening, everyone. I'm Shafin Fatima from C18 batch, and I'm delighted to welcome you all for today's episode of our optometry series. It's my pleasure to introduce our moderator for today, Mr. Amit Bhowmick. Amit sir is currently working as a senior optometrist in the binocular vision and vision therapy clinic at Shankar Nethralaya, Chennai. Sir completed his Master of Optometry from Dr. MGR Medical University, Chennai, and also completed a fellowship in binocular vision and vision therapy from the Shankar Nethralaya Academy. Sir is an active facilitator and speaker for continuing optometric education programs and has delivered numerous lectures on binocular vision and vision therapy. Sir has also published research papers in various scientific journals. With over a decade of experience, Sir has been a dedicated clinical instructor and a mentor to students. His current area of interest includes reading speed among Indian regional languages. We are truly honored to have you moderate today's session, sir.
Thank you, Saffin, for this introduction.
And moving on to our speaker for today's session, we have Mr. Kishan, a third-year optometry undergraduate student. Over to you, Kishan.
Good afternoon, everyone. Myself, Kishan, pursuing BS Optometry third year in Dr. Agarwal Institute of Optometry. I am curious to present you all about today's topic, that is disorders of extraocular muscles and cranial nerves. Recap of the previous session. The human ocular muscle system consists of extraocular muscles and intraocular muscles. The extraocular muscles are superior, inferior, medial, and lateral recti, and the superior inferior obliques. It also has lateral palpebral superioris and minor muscles. Alongside intraocular muscles are intraocular ciliary muscles and sphincter papillae and dilator papillae to maintain binocular circulation. Action. Each muscle has its individual actions such as medial rectus performs adduction, lateral rectus for abduction. Superior rectus has three functions such as elevation, adduction, intorsion. Inferior rectus depression, adduction, extorsion. Superior oblique performs intorsion, depression, and abduction. Inferior oblique involves extorsion, elevation, and abduction. Most extraocular muscles arise from the common tendinous ring, that is annulus of zinc, ensuring stable and coordinated eye movements. Its movements are controlled by cranial nerves and coordinated by neural laws for smooth and synchronized binocular vision. Any dysfunction of this muscle leads to conditions like strabismus, diplopia, ptosis, and nerve palsies. Cranial nerves are 12 pairs arising from the brain, controlling sensory, motor, fixed function of the head and neck. Names of cranial nerves involves first in a chronological order: olfactory nerve, optic nerve, oculomotor, trochlear nerve, trigeminal nerve, abducens, facial, vestibulocochlear nerve, glossopharyngeal, vagus, accessory, and hypoglossal nerve. These are classified into sensory, motor, and mixed. Functions include smell, vision, eye movements, facial sensations, expression, hearing, balance, swallowing, and tongue movements. Key ocular nerves that are important for ocular movements and vision. Second nerve for vision, third oculomotor nerve, most eye movements and pupillary reaction. Fourth nerve innervates superior oblique, and the sixth nerve innervates lateral rectus. Disorders of extraocular muscle. The group of disorders characterized by abnormal function of extraocular muscles or their neural control leads to defective ocular movements and misalignements of visual axis. Basic mechanism. Mostly these disorders are caused due to involvement of cranial nerves especially for ocular surface like third, fourth, and sixth nerve, neuromuscular junction, extraocular muscles, orbital structures causing mechanical restriction. Common manifestations: diplopia, also known as double vision, strabismus, limited or restricted eye movements, abnormal pose. Classification of EOM disorders. Risk of sixth classification: paralytic, neurogenic, restrictive mechanical, myogenic, congenital disorder, strabismus related, inflammatory, or traumatic. Paralytic disorders. It is a neurogenic disorder caused by dysfunction of cranial nerves supplying extraocular muscle, results in weakness or paralysis of one or two more muscles, which in turn produces concomitant strabismus, with meaning deviation varies with case. Cranial nerve involvement. Third nerve, oculomotor nerve, supplies medial rectus, superior rectus, inferior oblique, and levator palpebrae. Functions affected are adduction, elevation, depression, and eyelid movements. Fourth nerve, trochlear nerve, supplies superior oblique, which in turn gets affected, and the functions involves depression in adduction. Sixth nerve is abducens nerve, which supplies lateral rectus, and the function affected are abduction. Etiology. These disorders are caused mainly by microvascular ischemia, common in diabetes, hypertension, trauma, head injury, intracranial tumors or aneurysm, raised intracranial pressure, sixth nerve commonly affected. Infectious and inflammation, congenital nerve palsies. Pathology is as follows. A cranial nerve lesion is formed, which leads to loss of neural input to extraocular muscles. Affected muscle becomes paralyzed or weak. Opposing muscle acts unopposed, full size in opposite direction, leading to ocular misalignment and concomitant deviation. Misalignment of these visual axes causes diplopia. Patient adapts to compensatory head poses to maintain binocular single vision. The clinical features involves for each nerves are third nerve palsy, eye down and out position, ptosis, mydriasis, loss of accommodation. Fourth nerve palsy involves vertical diplopia, which worsens in down gaze, head tilt to opposite side, can be identified by Byle-Kosky sign. Sixth nerve palsy, esotropia in primary gaze, inability to abduct eye, diplopia worse on looking toward affected side. Clinical features: diplopia, binocular worsens in direction of action of weak muscle, limitation of ocular movements, maximum in field of action of affected muscles. Concomitant deviation, angle varies in different cases, compensatory at post. Diagnostic features: negative force reduction test, no mechanical restriction. Diplopia charts shows maximum suppression in direction of action of paralytic muscle. This chart shows underaction of the affected muscle and overaction of the antagonist muscle. Treatment involves treating the underlying causes such as diabetes, trauma, or intracranial pathology involved. Temporary relief involves occlusion therapy or prism for diplopia. Observation: many nerve palsies occur spontaneously, especially microvascular. Medical management: control systemic condition, manage inflammation if present. Botulinum toxin for temporary cases to reduce antagonist muscle. Surgical management indicated if no recovery, usually after 6 months. Muscle resection or resection procedure. supportive patient education and regular follow-up for recovery assessment. Destructive disorders. It is a mechanical disorder caused by mechanical limitation of extraocular muscle movement, where the muscles cannot move freely despite normal nerve supply, which leads to concomitant stiffness. Etiology. Thyroid eye disease, which is the most common, orbital fracture with muscle entrapment, orbital tumors or masses, orbital fibrosis, scarring, post-surgical or post-inflammatory adhesions. Pathophysiology. Uh, Mechanical restriction of muscle or surrounding tissue is present, which in turn affects the muscle cannot stretch or contract normally. Opposite muscle acts against the restriction, which causes limited movement of the muscle, leads to globe retraction or tightness in certain cases, resulting in misalignment and diplopia. Clinical features: limitation of movement, maximum in direction opposite to the restricted muscle. Diplopia, which worsens in specific gaze positions, pain or discomfort, especially in inflammatory cases, possible proptosis, mainly in thyroid eye disease. Diagnosis features. First Dutson test shows positive, which is a key feature to diagnose this disease. Normal nerve function, no true muscle paralysis. Imaging such as CT, MRI shows muscle enlargement, entrapment, or mass involvement. Clinical importance. Differentiation from paralytic disorder is critical. Guides management. Medical versus surgical is also important in these cases. Treatment. Treat the underlying causes such as thyroid control and trauma management. Medical therapy involves steroids in inflammatory conditions. Diplopia management involves prism for temporary occlusion. Surgical management release of restriction, example fracture repair. Strabismus surgery after surgery and regular follow-up and imaging when required. Myelinic disorders. These are the type of disorders caused by primary disease of extraocular muscles where the muscle itself is weak or dysfunctional, which is not nerve related. It is often bilateral and progressive. Most common causes are myasthenia gravis, chronic progressive external ophthalmoplegia, muscular dystrophies, and inflammatory myopathies. Pathophysiology. Primary defect in muscle fiber or neuromuscular transmission leading to reduced muscle contraction strength leads to fatigability or progressive weakness. Multiple muscle may involve and variable ocular misalignment may occur. No true mechanical restriction or nerve pulses. Clinical features. For myasthenia gravis, fluctuating ptosis and diplopia are seen, which worsens at the end of the day, improves with rest or eye test. CPU, a slowly progressive limitation of all eye movements, bilateral ptosis, minimal diplopia due to symmetrical involvement. Diagnostic features. First action to source negative, variable deviation on examination, special test involves my eye spec test to isolate myasthenia gravis, endophenium test, which is historical one, imaging usually normal. Treatment. Treat the underlying cause as usual. Myasthenia gravis, which is treated by anticholinesterase drugs, immunosuppressive therapy, supportive therapy such as prism for diplopia, ptosis management, and surgery only in limited cases. Congenital disorder. Congenital and extraocular muscle disorders are non-progressive developmental anomalies of the ocular muscles or their innervation that present in infancy and typically result in lifelong functional limitations of eye movement. Etiology. Abnormal development of cranial nerve nuclei or pathways, fibrosis or structural abnormality of muscles, congenital misfiring of innervation, genetic or idiopathic factors. Pathophysiology. Defective innervation or abnormal muscle structures may cause this type of extraocular muscle palsies, leads to limitation of specific eye movements, often associated with co-contraction or abnormal muscle action, resulting in concomitant strabismus and restricted gaze. Clinical features on common conditions. Duane's retraction syndrome, which shows limitation of abduction plus adduction, Globe retraction on adduction, narrowing of palpebral fissure. Brown syndrome. Restriction of elevation in adduction mimics inferior oblique palsy, mechanical restriction. Congenital fibrosis of extraocular muscles shows severe restriction of eye movements, ptosis, fixed abnormal eye position. Diagnostic features. History since birth shows its presence. Stable or slowly changing deviation. Forced section test shows positive or negative since Brown syndrome is involved. Imaging may show muscle or nerve anomalies. Treatment. Observation for mild cases. Amblyopia management such as patching, vision therapy, and prism. Surgical correction to improve alignment and exposure. It are not always restore full movement. Strabismus related disorders. Strabismic related disorders are condition of visual axis misalignment that occurs with or without primary muscle pathology and may manifest with either normal or abnormal motility. Common causes are imbalance between extraocular muscle actions, defective binocular vision development, refractive errors, especially hypertropia involving esotropia, neurological or sensory causes secondary to EOM dysfunction. Pathophysiology. Imbalance in muscular forces or fusion mechanism causing failure of binocular fusion. Deviation of one eye may occur and deviation may be constant or intermittent. In long-standing cases, suppression or abnormal retinal correspondence may occur. Clinical features. Ocular deviations such as visible misalignment may be seen. Diplopia in common in adults, rare in children due to suppression. Abnormal head posture in some cases, loss of binocular single vision, amblyopia. The classification is categorized based on direction, esotropia inward deviation, exotropia outward deviation, hypertropia upward and hypo as downward deviation. Based on the deviation, it is also classified as concomitant deviation, where the angle of deviation remains same in all directions. Inconvenient deviation, the angle varies with yes, often even related. Diagnostic features. Cover test and alternate cover test are used to diagnose. Measurement of deviation can be measured using prism or cover test. Assessment of ocular movements, binocular vision evaluation is also done. Treatment. Optical correction such as glasses for refractive error, amblyopia therapy, orthoptic exercises, prism for diplopia, and surgical alignment such as muscle recession and resection. Inflammatory or traumatic disorders. Inflammatory and traumatic disorders are acute conditions affecting the extraocular muscles or orbital structures that typically present with pain and restricted motility following injury or systemic inflammation. Etiology. Inflammatory causes orbital myositis, idiopathic orbital, inflammatory diseases such as pseudotumor, infections, autoimmune conditions, trauma, orbital fractures such as load fracture, direct muscle injury, cranial damage, post-surgical trauma. Pathophysiology. Inflammation which leads to edema or swelling of muscle leading to pain and restriction. In case of trauma, mechanical entrapment of muscle or nerve gets damaged, which results in limited movement of gaze and ocular movements. Some cases shows restrictive and paralytic components. Clinical features. Painful eye movement, which is a key feature in inflammation. Sudden onset diplopia, limitation of ocular movement, swelling, redness or proptosis, history of trauma in traumatic cases. Diagnostic features. Post-testing test shows positive in case of mechanical restriction. Imaging such as CT and MRI shows muscle enlargement, fracture or entrapment. Systemic evaluation shows infection or autoimmune cases. Common condition. Orbital myositis can be identified by acute pain and restricted eye movement, involvement of one or more muscles. Blowout fracture, inferior rectus entrapment, restricted upgaze plus diplopia, orbital cellulitis, swelling, fever limited eye movement. Clinical importance, often acute, symptomatic, requires urgent evaluation, may mimic restrictive or paralytic disorders, and early treatment prevents permanent damage. Treatments such as inflammatory systemic corticosteroids, antibiotics for infectious, immunosuppressive therapy, traumatic observation, surgical repair, supportive therapy such as pain management, and presence for diplopia. But cranial nerve disorders. The cranial nerve disorders are conditions affecting one or more of the 12 pairs of cranial nerves, resulting in sensory loss, motor dysfunction, autonomic abnormalities. Most cranial nerves are generally affected by microvascular conditions like diabetes, hypertension, trauma, mainly head injury, tumors such as intracranial or intraorbital, aneurysms, infectious such as meningitis, orbital cellulitis, demyelination, like optic neuritis, raised intracranial pressures. Cranial nerve 1, that is olfactory nerve. Disorders affecting the olfactory nerve, which leads to impaired smell sensation. Function. The olfactory nerve is normally function for sense of smell. Etiology. Head injury, specifically at the nose region. Viral infection, tumors, and neurodegenerative diseases. Pathology. Damage to olfactory receptor or tract. Impaired signal transmission to the muscles or skin involved. Anosmia, leading to loss of smell sensation. Clinical features: anosmia, hyposomia. Anosmia refers to loss of or partial or complete loss of smell sensation. Hyposomia is a confusion in the smell. Alternate taste perception. Investigations. Smell testing such as coffee, soap to various taste smell. MRI scan to test the brain functions. Treatment. Treat the root cause, often irreversible in trauma. Optic nerve conditions disorders. Disorders affecting visual pathway in optic nerve causes visual impairment. Function, visual and pupillary reflex. Etiology, optic neuritis such as demyelination, raised intracranial pressure leading to papillary edema, ischemic changes, and glaucoma. Pathology, optic nerve damage leading to reduced transmission of signals to the muscles involved and vision loss. Clinical features: decreased vision, clarity of afferent pupillary defect, visual field defects, pain in case of optic neuritis. Investigation: fundus exam, visual fields, and optic coherence tomography is done for ocular investigation. MRI is done for the overall evaluation. Treatment: steroids is used in case of optic neuritis, and mostly the underlying causes is treated. This shows the variations involving the other three ocular nerves involved. Features involve muscle supplied. That oculomotor nerve supplies medial rectus, superior rectus, inferior oblique, and levator palpebral superioris. And the trochlear nerve supplies superior oblique, abducens nerve supplies lateral rectus. Primary action lost when it get affected are: in case of oculomotor nerve, adduction, elevation, and depression are affected. In case of trochlear nerve, depression in adduction is affected. In the abduction nerve, abduction is affected. Eye position, it usually is down and out. Slight hypertropia is seen. Esotropia is seen in direction. Diplopia, oblique diplopia is seen. Vertical diplopia and horizontal diplopia respectively for each nerves. Diplopia worsens in all cases for the oculomotor nerve disorder and only in down case for trochlear nerve disorder, and looking towards the affected size in case of abduction disorder. Head posture. The head posture is affected minimally or none. In abduction nerve, face turn towards affected side, and in trochlear nerve, head tilt toward opposite side. Ptosis is present in oculomotor nerve disorder and absent in other two nerve disorders. Pupillary involvement is present in oculomotor nerve disorder and absent in other two disorders. Accommodation is lost in oculomotor nerve disorders and in abduction nerve and trochlear nerve shows normal accommodation. Common causes for oculomotor nerve disorders are aneurysm, diabetes, and trauma, and for trochlear nerve disorders are trauma and are usually congenital. And for abduction nerve disorders, raised intracranial pressure and diabetes. Special features of emergency people involved. Bioscopy test, that is spark free test to segregate the superior oblique muscles, and most common policy is abduction. Post duction shows negative in all cases. Sixth nerve pulses. Then trigeminal nerve. Disorders affecting trigeminal nerves causes sensory and reflex abnormalities. It usually affects functions such as spatial sensation, corneal reflex, and mastication. Etiology: trigeminal neuralgia, tumors, trauma, multiple sclerosis. Pathology involves nerve irritation or compression by external force, which leads to abnormal pain transmission. Clinical features: severe facial pain, neuralgia, loss of corneal sensation, absence of corneal reflex, risk of neurotropic arthritis. Investigation: corneal sensation test is done, MRI is also done. Treatment involves carbamazepine to treat the neuralgia and lubrication to prevent corneal protection. Cranial nerve 7. Facial nerve. Disorders affecting facial nerve causes facial muscle weakness, function, facial expression, eye closure, orbicularis oculi muscles is innervated, lacrimation. Etiology: Bell's palsy, viral infection, trauma, and tumors. Pathology involves facial nerve inflammation leading to muscle paralysis. Clinical features: facial asymmetry, lag of thumbness, also known as incomplete closure, reduced blinking, exposure keratitis. Investigations: clinical diagnosis is required and MRI in most cases if needed. Treatment: steroids, lubrication, and eye patching is required. Vestibulocochlear nerve. Disorders affecting hearing and balance caused when vestibulocochlear nerve is affected. And balance of the body. Etiology: vestibular disorders, tumors such as acoustic neuroma and vestibular system, impaired tinnitus, vertigo. Investigation: audiometry and MRI. Treatment: treat the root cause and vestibulocochlear rehabilitation. Glasopharyngeal nerve. Disorders affecting swallowing and taste involves glasopharyngeal disorder. Function: taste most posterior 1/3 of the tongue is innervated by glasopharyngeal nerve. Gag reflex. Etiology: neuralgia, tumors, stroke. Clinical features: loss of gag reflex, difficulty swallowing. Investigation: gag reflex testing. Treatment: treat the underlying cause. Vagus nerve. Disorders affecting autonomical and laryngeal functions. Functions involves parasympathetic control, voice and swallowing. Etiology: tumors, surgery, and stroke. Clinical features: hoarseness, dysphagia, uvula deviation. Investigation: laryngoscopy is done to get the vagus disorder. Treatment: wash therapy and treat the root cause. Accessory nerve is disorder affecting neck and shoulder movements. Function: SCM and trapezius muscles are innervated by accessory nerves. Clinical features: shoulder drop, weak head rotation is seen in these cases. Treatment: physiotherapy is done to innervate the accessory nerve. Hypoglossal. Disorders affecting tongue movements is a hypoglossal disorder. function. It usually innervates the tongue movement. Tongue deviates towards affected side, and this R3 is the clinical features. Underlying causes is treated to make the person normal. The references are Comprehensive Ophthalmology by A.K. Kurana. Thank you.
Thank you, Sam. You put it all the disorders in a short nutshell. Now I request the moderator to add your valuable clinical insight.
Thank you.
Hi, Kishan. It was a very nice presentation and detailed presentation of all nerves. Okay, very good.
Thank you, sir. Thank you, sir.
Okay. But as an optometrist, you are not dealing with all the nerves day in, day out. Few things only we are dealing, like second, third, fourth,
Yes,
and sixth. Yeah. So our main aim is to see the eye movement. And if you see, most probably third, fourth, and sixth nerve are responsible for this eye movement. And once they are getting affected, so you will see eye movement is restricted. Okay. Now for clinical aspect, I can say few points. Okay, one is uh, third nerve and this REPD. You told one point, a very good point, that pupil is dilated. Okay, so not always third nerve palsy is pupil dilated. Sometime without pupil dilation also third nerve palsy happen. So you have to check REPD properly. Now what happen if you see the anatomy part, the two nerves, two fibers actually, they are together forming the third nerve. One is somatomotor fiber and one is visceromotor fiber. And visceromotor fiber is up and somatomotor fiber is down. Okay, and they are just running from midbrain to cavernous sinus, and then lateral wall to the cavernous sinus, and then coming out from that, and then dividing into two part. Okay, so that's way they are going, and they are uh, meeting the muscles through superior orbital fissure. Okay, now if you see the course of the third nerve, the first fiber, which is visceromotor fiber, will be up and somatomotor fiber will be down. Okay, so now in case of any space occupying lesion, so suppose a tumor or any kind of mass, okay, if it is pressing on that course of the nerve, okay, so first it will press on the visceromotor fiber, and visceromotor is serving the ciliary muscles. So in that case, you will see a mid-dilated fixed pupil. Before restricted happen, so you'll see that mid-dilated pupil. So once you do a RAPD, you will understand whether this person having anything, any problem. We can suspect. You cannot diagnose anything, but you can suspect. Okay, maybe some neurological causes there. Okay, so this is one thing. Okay, now once the size of the mass or size of the lesion is increased, so slowly there will be pressure on the visceromotor. Through visceromotor, the pressure will go to somatomotor fibers, and you will see a restriction of eye movement. Okay, and same time you'll see a ptosis. Okay, these things happen. Okay, and if you see in other part, uh, diabetic patient, when you will see the aneurysm, microaneurysm. So what will happen once the microaneurysm forming near to the part? Okay, so they will reduce the blood supply. So once they are reducing the blood supply on the visceromotor part, it is getting less supply, and somatomotor part will get even less supply. Means they are not at all getting the good nutrition from the blood flow. Okay, so in that way, somatomotor fiber will get affected first, And as you know, somatomotor fiber is responsible for all other muscles except SO and LR. So you will see a restriction in a eye movement. So this is a ischemic cause, okay, where you will see first eye movement restriction, and slowly once the visuomotor fiber is getting affected, they will see a mid-dilated pupil, all these things, okay. So once you do a RAPT in your OPD, so you can suspect these things. Is and as you told, fourth node, and the interesting thing, fourth node near to third knob it is originating, and they are going backside of the midbrain, and full midbrain they are covering, and then they are supplying the superior oblique, okay. So once they are supplying the superior oblique, and once they are getting means in some way, if they are getting damaged, okay, so you will see a patient means complaining of vertical diplopia, okay, and they will have a head tilt, okay. So which side, if you see, this is a opposite side head tilt. And one more small observation, if you see, so they will have a torsional diplopia, not only the vertical, they will have a torsional diplopia. And what will cause that, this some SO is superior oblique, so to reduce the torsion, they will have a chin down, okay. So suppose I have a this eye SO palsy, so I'll have a head tilt opposite but chin down like this way, okay. So if you see, observe that person is coming inside the OPD and then having the abnormal head posture, you can just suspect that, okay. And for sixth nerve is a very easy nerve. It will originate from near to pons and medulla. So it is a pon to medullary junction. So it will go, and again it will go to the floor of the cavernous sinus, and then through uh, superior orbital fissure, it will supply the sixth LR, okay, lateral rectus, okay. Now once they are originating from the point, okay, and the same point, one more nerve is there, that is facial nerve, okay. So what will happen, that once this point are getting affected, sometime you will get a false sign of ESO. So some you will see ESO, and you are diagnosing, okay, maybe this person having a sixth nerve palsy, okay. So make sure that you are not getting the false sign. So what you'll do, so as the facial nerve is supplying like this way, okay, so you can ask patient to close the eye and take a bird, slowly touch here and ask whether they are feeling that sensation, okay. If they are feeling the sensation, that means you are correct, that is only sixth nerve palsy. If they are not getting any sensation, so that means the sensation is lost here. So somewhere it is seventh nerve, means facial nerve also involved in that, okay. So it is a false sign, so it's called for false sign, okay. And anything, any suspect all these things, you can send for a neuroimaging to rule out whether really it is there or other some causes are there, okay. So neuroimaging is a must, okay. And from optometry point of view, you can, yes, document the all gaze cover test and prisms, how much prisms is there, diplopia charting, you can document to see in follow-up cases how it is improving. Even we can check HES charting. So if you check a HES charting, you will have an idea, okay, which muscles is not working, okay. And prism, you can give a prism for single vision, okay. But in case of recent onset, so the point is, if it is a recent onset, I don't suggest any management to the patient, okay, because sometimes nerves having their recovery period, okay, it can recover their own, Okay, so you just ask them to cover the eye. You can ask her eye patching, what you told already. Okay, and just see after a month or two whether the angles are stable. If the angles are stable, then you can think about prism glasses and regain the fusion. Okay, and then maybe a month or two again you can review the and see whether angles are stable, and for surgical correction you can send them for surgical correction. Okay, these things, if you see, just observe the patient, how they are coming inside, whether they are coming main thing, sixth nerve palsy, they have a face turn in the same side, so they will have a ESO. So once they are having, suppose I have a ESO, I have a sixth nerve palsy here, so I'll have a same side face turn, so I'll turning my face same side. Okay, so that I can see the single image. Okay, and other things are very nicely you covered all the nerves actually. Yeah.
Thank you, sir.
Thank you, sir. Thank you for the nice explanations. From the student's perspective, we do have certain questions to be asked to you, sir.
Yeah.
The first question is, in case of early cranial nerve palsies, how do we differentiate decompensated phoria with generalized neurogenic palsy?
uh, See, early means is under 3, 4 and 6, correct? So these 3, 4 and 6 having their own features. Okay, and decompensate phoria having their own features. Okay, so once you ask the history and we can see a MRI report, you will nicely differentiate between both. Okay, so a fourth na palsy people will see with a head tilt and chin down. With a sixth na palsy, you will see a face turn. But if they are having a decompensate phoria, so maximum time decompensate phoria, you'll see a elder age. So you'll see a geriatric people. Sometime you can see adults also, but you will not see all these features there.
Thank you so much, sir. The next question is, what is the role of vergence and accommodation therapy in nerve palsies?
See, the meaning of palsy is something different. Okay, so palsy means there is no work. So if you, what, I don't know, if you try, uh, a patient can able to do. Okay, there is no role, and for an optometrist you have to see how you can regain their fusion through a prism glasses. But because of palsy they will not able to do any kind of therapy, so there is no role of therapy here. Okay.
Thank you so much, sir. The next question is, if
If
the
the
person
person
is
is
coming
coming
after
after
a
a
trauma
trauma
or
or
head
head
injury,
injury,
he
he
knows
knows
that
that
he
he
is
is
having
having
some
some
oculomotor
oculomotor
dysfunctions
dysfunctions
or
or
vestibular
vestibular
dysfunctions,
dysfunctions,
but
but
they
they
are
are
coming
coming
to
to
a
a
therapy
therapy
after
after
a
a
long
long
time
time
where
where
the
the
neuroplasticity
neuroplasticity
would
would
have
have
already
already
happened.
happened.
In
In
that
that
case,
case,
how
how
do
do
we
we
manage
manage
them,
them,
sir?
sir?
uh, uh, just coming, just tell again, not
A
A
person
person
who
who
has
has
RTA
RTA
or
or
any
any
head
head
injury,
injury,
he
he
okay.
knows
knows
he
he
is
is
suffering
suffering
with
with
any
any
oculomotor
oculomotor
dysfunctions
dysfunctions
or
or
any
any
kind
kind
of
of
body
body
balance
balance
disorders,
disorders,
but
but
they're
they're
coming
coming
to
to
us
us
in
in
a
a
later
later
stage
stage
for
for
therapy.
therapy.
How
How
do
do
we
we
manage
manage
them?
them?
Okay, okay. So if they are having this kind of problem, so, so you can just do a assessment, okay, and see how they are saccades, how they are reading speed, how their eye hand movement. Okay, and based on that you can take a call. Suppose mainly these people are RTA and stroke patient. Okay, so strokes, previously we used to see the stroke patient in elder age, means GTIT, but now you can see some adult also suffering that. Okay, so you just see that patient, how they are saccades, because mainly that saccades is getting affected. How it is getting affected now, our third nerve and your sixth nerve. So okay, So both are connected in a nucleus, okay, where the eye movement is initiating, occurs is initiating, okay. So once your eye is going right, one eye is going right, okay, other eye has to follow. So one will be going right, another will be going left to synchronize the eye movement, okay. And in these cases they will not have all these things, okay. They will have a difficulty in eye movement, they will have a difficulty in eye hand coordination. So in these cases you can easily train them, but not easily train them, you can train them, but based on the severity they have to take that, okay.
Yes, sir. Thank you so much. That's all with the Q&A session for today. Anshi ma'am, do you have any questions for a moderator, ma'am?
Thanks, Amit. Thanks, Kishan. Thanks, Meenakshi. I think it was a wonderful presentation. Kishan, it was very detailed. It was very nice. The way you had tabulated the cranial nerves and the disorders, very well done. And thank you so much, Amit, sir. I like the way how you were showing the hands and you were telling the nerve and how it was connecting. So it was like, you could actually see exactly how the nerves are connected. And that really should help students to understand how we should remember the anatomy. So once when we remember the anatomy, it becomes very easy for us to understand simple things, but it may be, yes, difficult for the patients, like how you said, Sekas, Pertzwitz, and fusional vergences, all those getting affected. So thank you so much from the clinical perspective, how you gave the input on how oculomotility disorders and clinical cranial nerves disorders are really helpful from an optometrist point of view and what we should check. So thank you so much, Amit sir, for bringing out all the points. And I think it was a very good session. We had a nice question answer session also. So thanks to both of you. Over to you, Gomati.
So well said, Anshi ma'am. It was a wonderful presentation. So first, starting to appreciate Kishan for his presentation. Very good presentation, Kishan. Best wishes for your future. And Meenakshi, thank you so much for the Q&A. And Anshi ma'am, thank you so much for joining. Last but not the least, the star for the day, Amit sir. It was wonderful explanation, Amit sir. We're so happy to have you with us for the day. Actually, the topic deserves you, or you deserve the topic. I don't know. But anyway, it's set and it is like a cake actually. So it was set so nicely for the episode. So thank you so much for joining us as the moderator, sir.
Thank you.
Yes, we like to host you on another wonderful platform in the near future, sir.
Okay, sure.
Thank you, sir. Dear audience, thank you all for your continuous support towards Optometry series. If you like this video, give a thumbs up and share with all your friends. The announcement for this particular week is, of course, we do have the Optometry Day coming up in the very next week, and we have got reels and video making competition. The details of the reels and video making competition will be provided in the description box. The admissions are open for fellowship and pan India internship in optometry at Dr. Agarwal's Institute of Optometry. If you want to know more about that, please check the description box for the registration. Thank you all so much. Thank you, sir. Bye, sir.